So this is supposed to be a case of DCIS. I remember we stopped there. So there were so many things. And so um I noticed that we have not been utilizing this tool very well. Unfortunately, my program said we should be doing that, and it is actually very, very useful. Believe me.
With okay.
Is There are some things that come along with this thing that okay, wow.
Is this one part of it too, Abi?
It's part of the exam, it's the part of the Q bank. They said to get more in depth to the questions, we should look at this in the Q
But
bank.
they will now write notes on it, Abi?
I have notes on it on every topic. So it's if we just want to do we are doing Q bank, we can as well do that. But if you really want to, I'm going to delete it
Okay.
and start a
What do you
new.
want to do? Hmm?
So I want us to review this DCIS very well. So it's not going to be that, it's not going to take much time because last time I actually did a lot of the review and though you were sleeping then, but
Hmm. Why
so
your father says he's sleepy?
are you really sleeping now?
No, I said, why are you emphasizing and repeating you were sleepy, sleepy? Yeah?
So no, I'm not emphasizing. I was like, I reviewed it then. So I don't think it was much beneficial to you then. So so DCIS is characterized
Okay.
by clonal proliferation of epithelial cells that are confined to the ductal and lobular system of the breast, meaning it does not invade the surrounding stroma. So, in terms of molecular background, the genomic alterations seen in invasive breast cancer are also seen in these cells, meaning that it is a direct precursor to invasive cancer.
Okay, now this note is in this same cool bank, Abi.
Yes,
I think we should be reading it.
that's what I'm saying. It's actually,
Hmm.
when I was able to soft tissue, after I read everything, I came back, I said that this news was very well curated in a way that made it even, it was even more robust than the explanation they used to give to the questions at the end. But it was like I was able to understand some things that were too summarized in the note earlier on. Challenges in diagnosis are because of numerous morphologic types, wide grade spectrum, there's low to high biologic heterogeneity, and many histologic mimics. Most cases are found during mammographic screening. How common is mammographic screening in Nigeria?
I don't know. I know people do it, but I don't know
Uh,
how often.
It's not like a national screening program.
I don't know. I'm not aware of that.
Maybe rich people or people that are more educated. Less
Hmm.
or people who has risk factors in their family or something. Less common presentations include nipple discharge. Do you know that BCS can be found in nipple discharge in people that
Hmm.
have papilloma and then they express the bloody discharge, intended for cytology or something, or for histology. Paget disease of the nipple also have associated DCIs. They can be, it can be, sometimes it can be in a palpable mass, but most times DCIs does not form a mass. The usual treatment involves three things you do for DCIs: complete excision of the breast, of the area of the DCIs, radiation and tamoxifen therapy. But these are plus or minus. It's not used. When do you use radiation? Based on our last discussion, last class,
Mm,
high grade,
greater than high grade. Okay.
high grade DCIs. Surveillance, close monitoring without immediate treatment will be suitable for low grade lesions at times. So those ones have low risk of recurrence. What's the prognosis of DCIs? You treat
Very good.
excellent,
Thank you.
long-term survival. So the person doesn't go on to develop breast cancer. Recurrence after treatment is less than 10%. Without treatment, what's the risk of progression to cancer?
1% per year of progression.
Risk of progression to receive cancer at the same time. So out of 100 people, the next year, one person will pick up the cancer. And also in 10 years, 10 people would have gotten cancer. Sad, you know. It's not, anyway, that's 1% per year. Risk of progression to invasive cancer at the same time. Um, Top differential diagnosis: UDH, EDH, lobular carcinoma in situ, your popular gynecomastoid hyperplasia, collagenous spherulosis, radiation atypia, invasive carcinoma, vascular invasion, chest wall recurrence of invasive carcinoma. I'm not listening to my messages, so can you imagine? Oh, wow. Sorry. Let's continue. Terminology. Terminology. Abbreviations include DCIS, LCIS, ADH, which stands for atypical ductal hyperplasia, FEE, flat epithelial atypia, UDH, usual ductal hyperplasia, invasive breast carcinoma. The ductal carcinoma is no longer recommended due to potential to confuse it with invasive ductal carcinoma. Ductal intraepithelial neoplasia, not all DNA subtypes equal to DCIS. Definition: clonal neoplastic proliferation of E-cadherin positive epithelial cells confined within duct and lobules. That's how you defined DCIs. So clonal proliferation actually refers to cancer. It's a clonal neoplastic proliferation of E-cadherin epithelial cell remaining confined within ducts and lobules. So
Incarnate positive, yes.
yeah, that are confined within ducts and lobules. If they are E-cadherin negative, that will be lobular carcinoma in situ. Let's look at DCIS versus IBC. IBC is invasive breast cancer. Both of them share the same molecular changes. DCIS, however, is restricted to the basement membrane. Myoepithelial cells will still be intact, though they can be reduced or show abnormal distribution. Progression: only a minority of DCIS cases progress to invasive breast cancer. Only a minority. Factors promoting invasion likely include changes in the myoepithelial stroma microenvironment, immune modulation, and loss of myoepithelial integrity. In terms of genomic insights, both DCIS and invasive breast cancer exhibit similar gene expression patterns, although they may vary in certain subclones. HER2 positive DCIS can be linked to HER2 negative IBC. That means a DCIS can initially be HER2 positive. When it progresses to cancer, it may lose the HER2 positivity. Precursor lesions to DCIS include flat epithelial atypia for low or intermediate grade DCIS. And high grade DCIS does not have a well-defined precursor. So tell me, what are the precursors to the DCIS?
Right, atypia, ADH.
Or is it for all DCIS?
No.
Only for low grade to intermediate grade DCIS.
Mm.
Does high grade DCIS have a precursor?
Not well defined.
Yes. What's another characteristic of high grade DCIS that low grade DCIS does not have? It's a continuous lesion. It does not skip. You understand?
Okay.
Remember.
Hmm. Hmm.
Yeah, I guess this is about making money. Okay. It is such a stand.
You also wait for your time. You will make your own money too.
I'm not interested in academics. That's an answer. Anyway, I feel academics takes more time. Well, private practice, you just practice to make your money and go.
Okay, you want private practice.
Yeah, something I can do, and I will not be tied down to research. You understand? Writing papers, literature review, all the kind of things.
Hmm. And you want to go with all your stuff.
I have way for missions, bro. I just want to have time. When I sign out cases, that's all for there. I go home, I focus on missions work. I can do research in missions work. I can draw programs. I can draw up things. That's better for me. So
Hmm.
high grade DCS, when high grade DCS is continuous. Remember, unlike low grade DCS that is, I can be discontinuous. I can have skip lesions. Do you remember from yesterday?
Hmm.
Good.
Hmm. Yeah.
So clinical epidemiology. DCS is rare in men and it's uncommon even in women before age 40. So 90% are detected via mammographic screening. 5% can appear as a mass, less than 5% for nipple discharge. That's why they say that all this self-breast examination is not as effective as
That is an
eh?
graphic. That is, yeah, that's true.
Less than
It's
1%,
only see.
less than
Hmm.
1% present as Paget disease of the nipple. Less than 1% present as Paget disease of the nipple.
Hmm.
Age and sex. Incidence doubles from 40 to 80 in screened populations. Okay. Less than 1% Paget disease of the nipple. Age and sex. Incidence doubles from 40 to 80 in screened populations. Okay, let's see.
Hmm.
Okay, sorry, I was blocking out. Okay, 1% Paget disease of the nipple. Okay, less than 1% from very rare in men, typically involving retroareolar duct. Treatment considerations. Define excision of DCIS. Complete excision. What do you mean by complete excision in DCIS in surgery?
The whole lesion is size with margin. What's the size of the margin?
With,
Within 2 minutes. Hmm?
with what?
With margin.
No, that's not definition of complete excision. What's complete excision definition?
Okay, what's the
Complete excision with clear margins greater than or equal to 2 millimeters.
okay.
We don't, the pathology, like
Hmm?
you don't define things without measurements. You don't,
Hmm?
you have to put measurements when you're dealing with all these things. So
Yeah.
margins must be greater than or equal to 2 millimeters or 0.2 cm. Mastectomy, how useful is mastectomy?
Hmm. Reduces recurrence.
So what? Less
Less
than.
than 10%.
When do you do sentinel lymph node biopsy?
When there is invasion, or when you suspect invasion,
When there's microinvasion. What we're talking about is the microinvasion. What is microinvasion?
greater than 1 millimeter.
Less than or equal to 1 millimeter. Less than or equal to. After 1 millimeter, what is it?
Okay, it's frank and similar.
That's that's
Invasive.
invasive cancer. And then you now start going with and so. Adjuvant therapy.
Hormone and radiation.
So we use tamoxifen. It reduces ER positive DCIS recurrence risk by 30 to 50%. Adjuvant therapy is actually after surgery, right? Do you agree with me?
Hmm?
Adjuvant therapy is therapy done after surgery, right or wrong?
Yeah, it's after.
Radiation cause recurrence by 50%, but does not improve overall survival. Prognosis. Standard treatment yields less than 5% breast cancer death rate at 20 years. The Recurrences can be ipsilateral DCIS and invasive breast cancer. Contralateral breast cancer, breast cancer is also a risk. Patients with DCIS generally have better overall survival due to what? Early detection. Imaging, mammography. DCIS appears as clusters of calcification, which we're going to see later. Mammographic findings often underestimate the true extent. MRI shows linear clumped enhancement, sensitive but not specific for routine screening. So this CIS only picks up 85% of cases. MRI has increased sensitivity and the rest, but I think it has better specificity as well. Pathology. What is the, let me rename this.
No prospective.
Sorry. What
Breat
minute?
Pathology. Have you used free chat GPT before?
I don't think so.
Mm,
Why? What do you ask?
okay, I wanted to know if all these, if you could s- store things this on it like this one.
I think I don't know. I've not really used it, but I've heard of it or maybe experimented a little bit with it. And I didn't start using ChatGPT until I read College of American Pathology recommending that pathologists and pathology residents should start using ChatGPT. So I told my program director, they looked at me as a strange guy. So I used it, it helped me a little bit helped me in my studies and everything. And I tried to recommend to my residents, senior residents, they shut me down. They kind of rebuked me seriously. They said I written a with error of things. I just went underground.
Mm.
Fortunately,
They do what?
that is filled with errors and everything. But over time, they kept improving and improving. And now, many people are now using it, even my seniors, I had to teach them how to, told them so many tricks. For one of my friends, my classmates, he has significantly improved. A lot of people are now using it. You understand? But initially, when I tried, I was one of the first people to start trying to listen in the department. Because I read an early article on it. They used to send us almost cap articles every day. Now there are a lot of research on it for exam purposes, for USM, all kind of researches have been done with GPT, like researching into its effectiveness and everything. But as far I don't longer read those things. I kind of have my own way of, the more I use it, the more I know how to use it. Like now, if you look at this, I have so many projects ongoing for missions, for my family, for different things. Understand? So I need to
Okay,
then,
you're still using it for information, information too.
eh?
They're using it for information too.
A lot of missions work is done with this strategy. A lot. In fact, look at this one is called day-to-day running of missions or house projects. It makes my life easy. I mean, it cuts down my work time for missions significantly. I want to get a lot of things turned around or very uh, a lot of things. Even when I went to teach PU students, I taught the master's degree students in BU and PhD students. I had a lecture with them. Before I went, they got like 1 month advance. I had to start a project. This was my coming ground round. I already have a project for it. Where is it, self? Where is ground round? Ground round preparation. I already have. So anything that's important to me that's a project, I start a project there, and that's why I keep developing it. So anytime I go back, everything is stored there. I need to pick up from where I start, and it has revolutionized my
But
life.
always, if you are going to be presenting academy, you will try and get reference because these things they may not give you reference, standard reference.
They give more than standard reference, more than that. I'm telling you. Look at it. You see this one, deep research. I have 24 prompts between now and May 12th. This deep research, I can generate significant amount of powerful literature review with a lot of references that make sense. In fact, I
Mhm.
even use it for mission. If I want to use it for mission, I can even use it for this deep research is very powerful for many things.
Okay, it has deep research too, Abi.
Yes, deep research is you can use and generate very comprehensive data with very powerful references. Just like, in fact, you can cheat your lecturer and generate something that even you as a human being find difficult to generate when it comes to literature review.
Okay, and it give you standard reference. Okay,
Yes,
share it with you.
very
Mm.
standard reference. I'm telling you, it will be as if somebody
Okay.
he just mimic all this work they used to do. Say literature review, it will do it very well for you.
Mhm.
Anyway,
Can create image.
yes. This one, I mean, there's so many things there. So if you start working or something, I would advise that if you don't mind, if you start doing pathology, it will make your life very easy. Don't make it
Mhm.
a friend. The way you use it, make it a friend. Ask it everything before you know it. And there are different levels of complexity. There's 4U, there's the most advanced O3. This 4 I use because it's good for most of my tasks. I don't want to be switching models. This one is this one is for mathematical, some many kind of models. Anyway, so the more you use it, just like Android phone, the more you use it, the more you become acquainted with it.
Okay.
So let's go to macroscopic, usually not grossly visible. Extensive sampling is crucial. Macroscopic, extensive sampling is crucial. Right.
Okay.
Okay. Macroscopic, it does not grossly visible. So you don't see this as a mass. High grade this cells may present as green, gritty areas with comedonecrosis.
Okay.
Microscopic, with that one is better seen than talked about. So if you look at this, let me review this. This says low grade cribriform pattern. See this cribriform pattern. Monomorphic cell population with low grade nuclei forming rounded cribriform species. Secretory material often supplies the nidus for calcification. Molecular mammography. This is high grade DCIs with commodity necrosis, extensive commodity necrosis in the middle. It has more classification than seen on mammography. We also have a periductal fibrosis. Sometimes they may form ill-defined masses. This is a cluster classification that may be seen on mammography. Sometimes the classifications can be linear and branching, like here, you see linear and branching. And they're associated with high-grade classification. This is a mass. Sometimes this cells are associated with a mass like fibroadenoma. For example, here, this is a fibroadenoma with this size, but it's not a very clear picture. MRI can be used to increase the sensitivity of these size, but it's not very specific. This is why the MRI can help in DCIs because Sometimes this CIS is surrounded by blood vessels. How do you know that? If you do CD31, you will see blood vessel. If you see the blood vessel marker, you see surrounding the base of this CIS, so it can help to outline it. This is a DCIS with common necrosis. You see some of the ducts here have necrotic materials in them. This is a low-grade DCI because the nuclei are not very pleomorphic. The nuclei have normal chromatin or thereabout, but they have a central necrosis. Central necrosis is associated with associated with all kinds of things, including ADH. ADH can have necrosis. UDH can have necrosis. But common necrosis is usually very, very extensive.
Mm.
This is papillary and micropapillary DCIs. Papillary will have fibrovascular core, while micropapillary will not have. The thing about micropapillary is that it has a narrow base. It's a narrow base with a broad um, bulging tips. And these bulging tips will sometimes be hyperchromatic. Okay. Now, when you do DCIs, there's some in labs where they have double stains for DCIs. For example, now they have P63 to stain the epithelial cells, and they have E13 to stain the intraluminal cells. So if you look at it now, the intraluminal cells stain positive for E1, E3, showing these epithelial cells, but the basal cells stain P63. So normally, you should have seen this papillary kind of papillary pattern. You should have seen, if this was papilloma, intraductal papilloma, you see P63 inside and P63 outside. But you see this dark brown P63 is only outside by A1, A3. So there's no P63 inside here. That's what they're doing with DCIs. That all these plastic cells have lost their myepithelial layer, but outside is still preserved myepithelial layer. This is DCIs, the papillary and micropapillary pattern. This is high grade solid DCIs. High grade because it has prominent nucleoli, clear chromatin. You understand? Normally, common necrosis and that sign of high grade. This is clinging pattern DCIs. As I say, the DCIs is DCIs, but you see, they say they are clinging to the walls. As if they are dilapidated bricks trying to cling to the wall.
Where is this deeper repeated drill in pathology?
I think you want in them for them parts. There's remind me in them part. There's one part where you see dilapidated bricks.
Early disease.
Early,
Early disease.
early disease. Oh yes, in them part.
Mm.
What is the early disease again? Tell me. Spell it, please.
Hailey.
1 minute, please.
Early, yes. Mm. So it's going to be like intraepidermal bullet, but you run from one end to another end.
Benign familial chronic patient, rare autosomal dominant, recurrent vesicle crested, infantilysis, loss of cohesion between keratinocytes, dilapidated brick wall appearance is the hallmark. Early disease. Look at histology pictures. And you read a lot of you read them part very well. Oh.
Mm.
Why do you like them part?
Okay. Mm. Well, um, it's attractive to me.
Them part is a very, very
So
it's very, very lucrative specialty here in the US. Very, very lucrative. Okay.
to ATP2C1 gene mutation.
You see?
Okay. I said it is associated with ATP2C1 gene mutation.
Again, I didn't get that.
I mean, a Lilly disease is there's a gene defect mutation in it, like ATPC1 gene mutation. But let's continue because let's see that's the wolf. Let's look at histology again.
Is it
The
really?
latest one. The first one that delivered, let's look at it.
Which one? This one. Okay.
This one is this thing from the activity.
Hmm?
This thing you are looking at.
Is it
This
what?
diagram is it from ChatGPT?
Yes. It didn't generate. It just picked it randomly from the internet for me. It didn't generate it. So I can pick up pictures for
Mm.
you. Like this is Haley the dilapidated brick. This so it's ATP1C, right? ATP2C1.
Mm.
Good. We used to, the lecturer told us this in the dental class. So, but you see,
Okay, let's
sometimes
continue.
you can have this containing mucin and rupture and go to the stroma. If you're not careful, you may call it mucinous carcinoma. But if you don't see cancer circulating in mucin, then that mucin is not important. So sometimes these cells can be heterogeneous. You have some parts that is LCIS and some parts that is DCIS. This can involve Paget disease. This is two new staining in DCIS. This is ER will be positive in DCIS. This is heterogeneous DCIS. This part is loss of E cadherin. This part has E cadherin. This part has loss of E cadherin is lobular carcinoma in situ. This is ductal carcinoma in situ. Sometimes you can see them coexisting, mixing together, making life more complex for everyone. Sometimes DCIS involves sclerosing adenosis. Uh, you know, this is DCIS with microinvasion. You can see the myepithelial cells, the brown myepithelial cells surrounding the base, surrounding the base here, the basal myepithelial base here.
Mm.
Here, these infiltrating cells have no myepithelial cells, so this is microinvasive carcinoma. What do we call it microinvasive? Because if you measure this one, it's less than 1 millimeter. Perhaps I don't know. I think it should be invasive because these areas, unless these areas have myepithelial cells, but it does not have myepithelial cell. That's the thing. Then we talked about the sampling yesterday. When you want to sample, you sample contiguously. If it's only one if only one slide that has DCIs, this is the largest, is the extent of the DCIs. What if DCIs is present in multiple slides? You count the number of slides multiplied by the thickness. Okay, so if you have 5 slides times 0.4 millimeters, that's why you take contiguous sections for this.
Mm.
And this is a UDH with central necrosis. So if you are suspecting UDH, then you do CK56. CK56 will be mosaic pattern in UDH, but negative in DCIS. CK56 is what you use to differentiate DCIS from anything. This DCIS is LCIS. Let's see. This is gynecomastoid hyperplasia in a female. This is collagenous
Oh,
ferrulosis.
let me see. Let me look at that proliferation again, just for refresh.
What one?
Proliferation of luminal and my epithelial cells, the largest cells are certain species that are filled with treatment of the life material. Okay.
We will come to this the collagenous ferrulosis is a whole topic on its own. We need to look at it later, sometime in the future. Invasive cancer. Hopefully, before we finish breast, if we didn't come across it again, if we don't come across it again, we can look at. But I have to look at it. Collagenous ferrulosis is very important. Okay. So the molecular profile, PIK3ACE, TP53, GATA3. Of course, it's mainly lumina A, it can be lumina A, lumina B. It's ER positive, PR positive.
It's very,
And slightly testing. My epithelial markers like P63, CK56 can help differentiate these cells from microvesic carcinoma. Remember that CK56 will only stain in my epithelial cells of these cells. It doesn't stain inside. If CK5 stains
Hmm.
inside, it stains the luminal cells. What is that? UDH. Okay.
Okay.
A-cadherin is positive in DCIS, negative in LCIS. AR and HER2 new can guide adjuvant treatment. UDH versus DCIS. UDH will be heterogeneous population of cells, mixed cell population. DCIS is clonal and monomorphic. ADH versus DCIS. That's where I apply size criteria. Less than 0.2 cm, we call it ADH, even if it looks like DCIS. Or with just one single duct that is involved in the whole of the area looking at just one single duct, then that's ADH. That different have cells distinguish ADH. LCIS and DCIS sometimes can be difficult. Let's use E-cadherin. Which one will be E-cadherin positive?
Let's see. Oh, this yes.
DCIS, yes. Collagenous pherolysis and radiation ATP are mimic cubiform DCIS, but have my epithelial rich architecture. I think we should look at collagenous pherolysis quickly because if you don't mind, I can look at it because there's collagenous pherolysis. Can you tell me how you differentiate how collagenous pherolysis will be different from cubiform DCIs? Do you know collagenous pherolysis? Do you know what it means?
And they have like membranous like material in cubiform species, and then surrounded by myoepithelial cell proliferation. There is no ATP like you see, you know, no ATP like you see in Dr. Carcinoma inside to no necrosis.
Have you seen a case of
Um,
collagenous pherolysis before?
Nothing really. I've seen it in textbook.
Very good. I mean, you are very, very good. This is collagenous pherolysis. In collagenous pherolysis, you can see it looks like cribriform DCIs. However, there's a benign proliferation of luminal or myepithelial cells. The cribriform pattern is formed by true lumina. You see this cribriform pattern? This is where you have the true lumina. And the seminal, sorry, the cribriform pattern is formed by true lumina, these parts. And the pseudolumina that surrounds the basement membrane-like material. So, sorry, this is the true lumina. The true lumina, there's a true lumina, there's a pseudolumina. The true lumina has, well, all of them has basement membrane-like material inside. But the true lumina has what we call, there's some tufting of the membrane. There's some undulation in the membrane, which we're going to see later. There's how this basement membrane like lamina, but basement membrane like material, and the pseudolamina have cuticle. It's round cuticle surrounding the basement membrane like material. The pseudolamina is the one that have myepithelial cells surrounding it, right? The true lumina does not have myepithelial cells. So normally in DCIs, myepithelial cells will only be outside. But when you start seeing basement membrane like materials, you start thinking of collagenous pherolysis. Usually there's a cuticle, and then you don't do P63. Now see this cribriform area surrounded by epithelial cells. It's like the pseudolumina. There, that's confirmed collagenous pherolysis. It's a happy picture. So you see here, the epithelial cells are filled with basement membrane-like material, which have a loose fibrillary texture or thick peripheral cuticle. You know, it's cuticle. Even when the central area appears empty, sometimes even when it's empty, you still have this peripheral cuticle. You know, in contrast, the true lumina can be seen on luminas have apical blebs. You can see this is a true lumina. This ones have true luminal blebs. Look at this one have cuticle. This one have a bleb, a bleb. You see them having blebs, you know. This building membrane like material, true cuticle. Let's see. This is the true cuticle, this is a peripheral cuticle. This is a fibrillary basement membrane like that material. This is a mucinous appearing basement membrane like material. This is a targetoid appearing basement membrane like material. Um, this for the pseudolaminate. This surrounded by epithelial cells. Then this is membrane-like material surrounded by my epithelial cells. These are my epithelial cells. No. Very good now. You now do P63.
Mm.
When you do P63 staining, you will see that the P63 epithelial cells are going to surround those pseudolamina. Okay. Luminal cells will show. Now, these ones that are not staining are true luminal cells. If you look at the true luminal, look at this one. This is the true luminal cells that do not have. These are the pseudolamina. The pseudolamina have P63 around them. That's why you see them staining. The true lumina one, see this apical bleb, apical bleb, apical bleb. You know? So the true lumina, now when you look at under H and A, you see that the true lumina have apical blebs and surrounding basement membrane material, while the pseudolamina have cuticles, peripheral cuticle, pink eosinophilic cuticle. When you do P63, you see that the pseudolamina will stain with epithelial cells surrounding it, P63. But the true luminal ones, those apical blebs, will not stain because it's only luminal cells that surround them. So that's what they are saying here. That I think that's enough. That's what they are saying here. That collagenous ferrulosis and radiation ATPR may mimic from these cells, but they have my epithelial rich architecture. And radiation ATPR. Let me see. Radiation ATPR is not something that the radiation ATPR. Oh, let's leave that for another day. Okay, good. So, let's review this. Let's review this. Then we'll answer our questions and be done. So, we want to know why our answers are correct, our answers are wrong. Statement one was say that a reporting DCIS, nuclear grid, histology, distance from margin, and extent of distribution should be given. And the answer is true. This statement is true. The 2009 College of American Pathology Protocol reporting recommendation for DCIS includes nuclear grid, histology, distance from margin, and extent of distribution. Are you there?
And yeah, yeah, yes. Sorry, let me just look at it again. The commission, nuclear grade, histology, distance from margin, and extent of distribution.
What is complete excision?
Include the excision plus 2 millimeter margin.
What is complete excision?
Complete excision of the lesion with 2 millimeter margin.
This is equal to 2 millimeters. Yes. Mm. Just a minute, please. Let's continue. Okay, because the 9 cap protocol. Let me see. Okay, so manage to because all these elements are standard reporting guidelines to guide management decisions and assess recurrence risk. Okay. Growth pattern of high grade versus low grade DCIS. According to the statement, high grade DCIS frequently shows a discontinuous distribution and growth pattern in dots. Low grade DCIS shows continuous distribution. True or false statements?
So that I don't get it. It is high grade that shows
Three
continuous.
statements and see if it's true or false.
High grade shows continuous distribution. To, the statement will be false.
Yeah. What's the correct thing?
Is high grade shows
Continuous.
the continuous
While low grade shows
discontinuous.
continuous. Three-dimensional imaging analysis of the distribution of DCS doc shows that DCS in high grade is in approximately 90% of cases show continuous growth pattern without gaps within ducts. Low grade DCS shows a discontinuous pattern of growth with intervening normal duct epithelium. Recent 3D images have shown that high grade DCS more than 90% shows continuous solid pattern within the duct without gaps, while low grade show discontinuous. Statement is false. Statement. Both lobular disc, LCIS, and ADH are associated with bilateral risk of developing invasive cancer, while DCI is associated with increase of invasive cancer, which is primarily ipsilateral. True or false?
More
True.
yes, yes.
Molecular profile of high grade. Now, molecular profile. High grade DCIS is associated with P53 mutation and HER2 new overexpression and a high KR67 rate, while low grade DCIS is associated with PR expression and BCL2 expression. True or false?
That sounds true, is it? I agree. So,
Actually true because high grade DCIS has P53 mutations, HER2 overexpression, high KR67, while low grade DCIS has strong ARPR expression and BCL2. So BCL2 positivity is and ERP are low grade features. While P53 HER2 overexpression and high KR67 is high grade DCIS features. Let me see if I can. I don't know why they didn't deal with that here because I think they should have done that. They should have done that here because I saw it in one of that texts. I read yesterday. I'm disappointed that they didn't do that. Okay. Finally, the Van Nuys Prognostic Index. In the Van Nuys Prognostic Index for DCIS Institute, a score of 1 to 3 is given for each of the following: nuclear grade, size, and distance from margin.
nuclear grades.
So the VMPI, they give scores to nuclear grade or necrosis. Necrosis is already grade 3. Don't forget to. If you have comedonal necrosis,
Okay.
that's grade 3. Not all kind of necrosis, but comedonal type is extensive. Then size of the lesion, then surgical margin, and now they have added the fourth category, which is age. So So let quickly review this one and we are done. Uh, DCIS. High grade DCIS, this is when I talk about it. High grade DCIS is associated with what? Higher local recurrence after breast conserving surgery. And it's associated with P53 overexpression, HER2 new amplification of overexpression, high KI67, ER, the right low one is ER positive, BCL2 positive. This is actually the Van Noise prognostic index. Can you read it out?
Van's productive index scoring system that stratifies the SC pattern. And it's based on the risk of recurrence after treatment. We have three categories, which are location size, nuclear grade, and distance from margin. Location size, 1 point less than 15 mm, 2 point between 16 and 40 mm, 3 points greater than 40 mm. Nuclear grade, 1 point is low grade, 2 point intermediate grade, 3 point is high grade. Then distance from margin, 1 point greater than 10 millimeter, 2.1 to 9 millimeter, then 3 points less than 1 mm. So risk category, we have low risk, intermediate risk, and high risk. Low risk 3 to 4, intermediate risk 5 to 7, high risk 8 to 9. So you have size, nuclear grade, and distance from margin. It's more or less like this TNA. T
Yeah.
is like size,
No, that's not
N is
that's like not
because it's not node. It's not node. Just like nothing and the umbrella.
yes.
Nuclear polymorphism, but instead of mitosis, you have distance from margin. T is size.
Mm.
Okay. So the skin conversation. Let me look at the name of the building again. Barnos Prognostic Index.
Mm. Continue now. Treatment implication.
Okay, treatment indication. Low risk may not benefit from radiation therapy post surgery. High risk prepare despite radiation, require immune eye. Mastectomy may be advised. Then age has been acted as a fourth factor because younger patients, less than 40 years, seem to have a higher recurrence rates. So key insight, distance from the margin greater than 1 centimeter appears predictive of a low recurrence rate. It still requires further validation in broader patient population.
Like a bilateral versus ipsilateral risk of invasive cancer. LCIS risk of cancer is what? 8 to 10 times.
Yeah, that's true. ADH 4 to 5 times.
ADH 4 to 5 times. And both of them are bilateral. But DCIS
Hmm.
is ipsilateral 95% of cases. Relative risk is 8 to 10 times. Important when counseling patients. Micropopularity DCIS and good patterns. Because well differentiated low, if somebody has low DCIS, the problem with It's high DCIs actually. When you do surgery, you can get away with a margin of less than or equal to 2 millimeter for high grade DCIs, but not for low grade DCIs. Why?
So I didn't get your question.
When you do surgery and do a complete excision of the breast and you find high grade DCIs, a margin of less than or equal to 2 millimeter is okay. But for low DCIs, you want a margin of 1 cm. Why?
Mm.
Because
Wow.
it skips lesion, it skips areas. Do you understand?
Mm-hmm.
The high grade DCIs is continuous. So when you excise it, when you know where it stops, it has stopped. But this one skips lesions. What if you see a margin of 5 millimeter and it just means that it just skipped like 1 cm? It can skip up, it has gaps, but the gaps are usually less than 1 cm. Do you understand?
Mm-hmm. Yeah,
So
yeah.
if you have a margin more than 1 cm, you'll be more confident. But if your margin is less than 1 cm, these tumors have been known to have gaps, sometimes up to 9 millimeter gaps or something like that. You understand? But it
Mm-hmm.
skips. You want the distance of 1 cm. Okay.
Mm.
Does it make sense?
Yeah, it does.
Final process.
Mm.
So the following features is not routinely included in the pathology report of DCIS.
Two status.
Yes. That's more for prognosis for dealing with high grade DCIS. But normally we put the high grade, we grade the nuclear grade. In terms of nuclear grade, don't forget that necrosis, combined necrosis is going to give you nuclear grade 3 automatically. Okay. So nuclear grade, distance from margin, size. High grade DCIS is most strongly associated with what?
I2 positive,
What's
P52
special
positive.
classification, extent of lesion and distance from margin? Sorry. Okay. AAD cells has a 2 P53 and high KI67. The one I'm MIB1 is the same as high KI67, right?
Mm.
What will low grade DCIs show what will the immuno profile of low grade DCIs?
No grade, no grade, no grade, no grade, no grade.
AR positive, BR positive, and BCL2 positive.
Yeah,
In the VNPI, Van Noy's prognostic index, what score is assigned for a DCIs lesion size of 25 millimeter?
it's two.
Less than 1 is for less than 15 millimeter, 2 is 16 to 40, and greater than 3 is greater than 40 millimeter. Which factor is considered most predictive of low recurrence in these cells based on recent Van Noy studies?
Distance from the margin.
The best is greater than what? 1 cm.
Mm.
Which of the following best describe the relative risk of developing invasive cancer in patients with DCIS?
85 times.
To 10 times. What is the predominant
Okay,
this size delta growth in high-grade this size based on 3D imaging?
this continuous growth without gas.
In GNPI, what score is assigned for nuclear grade for the nuclear grade of high-grade this size?
That's three.
3 is high. Yes. Which DCI subtype is noted for having a wide distribution regardless of nuclear grade?
Micropapillary.
I'm not too sure of this, but I don't understand more.
You
Why did you
have
across
a
dot?
related.
What does it mean?
Why do you across the
Hmm. What does this mean? You know what it means?
hmm?
You know what this means? Maybe we can copy it out.
Louis away. That's me. Um, brother, I had interruption.
Okay, okay.
Mm.